question going back to the pathology diagnosis of the different types of PMP. I mean, if basically the treatment is CRT and HIPEC for every type, what value does the type really bring? And also, how do you find out the type until basically post-surgery when you're able to do the pathology analysis?
Well, some patients will get a biopsy. I mean, we get patients after small operations, more larger operations, and even cytoreductive surgery, incomplete, that come to us. So there's often some tissue before we evaluate patients. If somebody has a thought that they have an appendicitis, they put the laparoscope in. There'll be something there that can be evaluated. And I think some of the points that Laura made is that there's different terminology in different centers. When we see patients, we often get our language, by having our pathologists look at the material, which anybody who has an operation, there'll be material that's archived in formalin, so it can be evaluated, again by a different group of pathologists that can then put it into, at least at Pittsburgh we see a lot of patients, I'm sure the other major centers do, so that they can put it in a language, and often it's different. I mean, you can sort of read between the lines from somebody who's coming from a smaller community hospital, and where they're calling it using favorable words and suggesting that it's cancer, but a more favorable cancer. And often, when our pathologists look at it, they'll put a DPAM term in it. But again, none of this stuff is 100% accurate. It gives us some idea of what the prognosis is, what the outlook is going forward. But I always caution that it's imprecise. We have patients that we think have DPAM and things are going to go very well, who recur fast in a year or less, and so it's never 100% accurate. So even though we do get the terminology, there's always some uncertainty as to how things are going to play out going forward.
Cancer has a mind of its own.
I mean, a lot needs to happen. We need to look. We are moving from having this general pathology evaluation on what we call immunostaining, just putting some ink and trying to figure out, what the tumor is, to moving to more gene analysis. Now we are far from that point, but getting closer, looking to characteristics of the tumor to help to predict response and whether they can be treated or not, or should be treated. Now, for example, we know that if you have a true DPAM, for example, you don't need a right colectomy. You just remove the appendix with clear margin and clean everything else, and you don't need a right colectomy. If you have the more invasive tumor, then you should have a right colectomy, because that tumor will tend to go to the lymph nodes, which is another prognostic indicator that is important for us to know. But then comes the issue about chemotherapy. I have patients who had advanced cancers that refused chemotherapy that are alive and well 5 years later, which I was suggesting that they should have taken chemotherapy. And we have people with what we call DPAM that we thought we were doing great, and they recurred. And you have to show you everything look clear. Now, talking about the diagnosis, one of the common problems that we see is laparoscopy. When I say laparoscopy, is that these tumors have the propensity to recur wherever you make a hole. So laparoscopy, of course, you have 3 or 4 courses, you get appendectomy, and not infrequently we'll see this tumor growing out of the areas where the port was placed. So if we are going to do a diagnosis of, we came with a diagnosis of possible appendiceal tumor, we do all the ports in the midline. Why? Because it's very easy to remove and not so much surgery or problems down the line. And when you have the abdominal wall, just put in a port, doesn't necessarily go directly. You really are going at different levels, so sometimes you can, unless you see a growing tumor, you have no idea where the tumor was implanted, so you may do a complete removal of the tumor to know that a year or 2 later that things are growing out of the abdominal wall at different levels. So it's a lot of also teaching along those lines. Now, ideally, you have a CAT scan. Now we do CAT scan for everything. It really, you go with the abdominal to the emergency room for something, you get a CAT scan. So now we see this tumor that looks like an appendiceal tumor, and then they go straight for the wrong operation, when that patient should then at that time be referred to do one operation and do it. And why that is not changed, I think, it's a lot of teaching that needs to go to radiologists and primary care and surgeons and so on.
I haven't yet figured out the direct outreach to insurance companies, like we're saving you a ton of dough by doing the right operation the first time. But that needs to happen too. I just haven't quite figured that one out.